Hi, everyone. It's Erica and Jenna here. This is the material to cover for our clinical simulation class on Thursday. We will be going over obstetric hemorrhage, and we will be covering what to look for. And then we are going to give you guys a scenario at the end, which you will be going through step by step in our simulation on Thursday. So for this group, we will be doing undergraduate nursing class. The age demographic is 18 to 20 years old with 25% male and 75% female. Our lecture class is 50 to 80 students, but for this specific day, we will be doing small groups of 6 to 8 students. So we will assign those groups and post them online. And then we've also opened discussion groups for your groups. So we open discussion boards where everyone can go after reviewing this content and post any questions and kind of start thinking about what to look forward to and how you would handle any type of hemorrhage on Thursday. Erica and myself will also be in those groups and can answer any preliminary questions that do not pertain to the direct care of the patient. The goal of this is to have you guys obtain new information. It's not something that you necessarily see in clinicals often. So we want to expose you guys because while you're actually, if you choose to go into labor and delivery, it is something that you could possibly see and need to know how to report and treat. And we also want to be able to have you guys be able to apply this information in the real world.
All right, so I'm Erica. I'll go a little bit over what obstetric hemorrhage is. First things first, we want to know what is a hemorrhage. Basically, a hemorrhage is another term for profuse, uncontrolled bleeding that, if not treated immediately, could lead to hypovolemia, hypovolemic shock, organ failure, and death. In obstetrics, an obstetric hemorrhage is the same thing except for the fact that instead of dealing with a blood vessel, it's dealing with the uterus. So obstetric hemorrhage is an excessive bleeding related to pregnancy that is caused by disruption of the 4Ts. First T is uterine tone. So basically, when the baby and placenta are born, the uterus is a muscle and its job is to tone and firm up to control bleeding and to eventually stop bleeding. When that is disrupted, you'll notice that the uterus feels boggy when you do fundal massages, and the patient continues to bleed. Retained tissue is the second T. That's involving the placenta. So when the placenta is delivered, the physician looks over it to make sure there are no pieces missing. If a piece is found to be missing from the placenta, it's generally still attached to the uterus. This causes the uterus to still feel boggy. It will not firm up, therefore contributing to the mother bleeding. Trauma is the third T. So that can happen with lacerations or hematomas. Generally, when moms deliver babies, they can tear. That causes a laceration within the uterus. It can cause the laceration within the cervix or the vagina. So if the physician looks over the area and finds that there is a laceration, but they don't repair it accurately, the mom can continue to bleed, causing her to lose blood. And with a hematoma, that's basically a collection of blood that's within that can actually cause mom to lose blood internally. And thrombin is the last T. So this is a coagulation disorder. It can happen if mom is anemic or if she has another hematologic disorder like hemophilia, where her platelets don't clot like they should. This will cause her to bleed. So obstetric hemorrhages come in stages. Any bleeding less than 500 mLs is considered a minor to mild hemorrhage, generally with fundal massages and IV fluids, and monitoring. The nurse can actually prevent a hemorrhage. A hemorrhage of 500 mLs is considered moderate. This is where you want to get medications introduced to help with firming the uterus to prevent excessive bleeding. A loss of 1,500 mLs or more is considered a severe hemorrhage. This is calls for immediate intervention, and if care is delayed, moms can suffer from hypovolemia, shock, organ failure, and death.
Okay, so our goal for this is cognitive learning. So we've included subtitles so people can follow along that way. We also recorded this PowerPoint so anyone can go back and review it and take the notes necessary. We recommend printing out the PowerPoint and taking notes. In a few minutes, Erica's going to give you the scenario that we'll actually be addressing on Thursday. So for this this topic, we're going to be focusing on cognitive learning, which is active learning. So we want the learner to be able to focus on the new information, but also apply it. So this is helping you guys focus on that information, and then you guys will be able to apply it through the simulation. There are 6 stepping stones. So we want there will be an assigned reading for this. Have the students read that, and then you guys will watch this PowerPoint. Like I said, the PowerPoint will continue on with different pieces of information, and then go ahead and take notes because it will be what we're reviewing on Thursday. So then you must be able to define it and then provide examples. We'll give you the main scenario. There may be small other scenarios on Thursday that we'll address at that time. Also, we will take a brief 15 to 20 minutes before going into simulation to review any possibility of any students seeing this actually happen in clinicals over the last 5 to 6 weeks in your labor and delivery clinicals, discuss how they felt, what they saw, what the treatment plan was, and what the follow-up monitoring was. And then we will have the group analyze different ways that these hemorrhages can occur, which ones are more terminal. And then Erica kind of went over the other parts here. And then we'll have each group go into simulation, and then we'll provide formal feedback. So the simulation will be recorded. It'll be a group of 6 to 8 nurses. So there may be one primary nurse. The team comes in to help when the hemorrhage is identified. We'll have someone act as a physician, and then we will review as a group and discuss what you felt, strengths, weaknesses, what could have done differently, and what the treatment plan should look like. And then we'll have everyone turn that into either a PowerPoint or a handout, which can be reviewed in our large group class of 50 to 80 people. So Erica's going to go ahead and describe the scenario that we'll see on Thursday. And like we said, any questions can be posted in the discussion board and we can answer from there.
So our scenario includes a pregnant female. This is AW. She is a 29-year-old G1 P0. She's 39 weeks, and her estimated due date is March 3rd of 2023. She has a minimal medical history of asthma, anxiety, and anemia. She has had an uneventful pregnancy thus far. On her last ultrasound visit, the fetus was measuring at 10 pounds and just between 21 and 22 inches. AW is also 5 feet tall. Her husband is just over 6 feet. So she has been a little worried about delivering her baby. Labs were drawn when she was admitted to the hospital. Her hemoglobin is 9.9. Her hematocrit is 29.7, and her platelets are 135. Normal hemoglobin for pregnant females is 12 to 16, and the platelet level should be in between 450 and 500,000. So after several hours in labor, including 2 hours of pushing, 1 hour of laboring down, and another hour and a half of pushing, AW finally gave birth to a healthy baby boy. He weighed in at 10 pounds, 3 ounces, and was 22 and a half inches long. During the postpartum period, the physician notices that her bleeding is not being controlled. That would be the scenario for our next clinical skills lab. So with the readings that you are required to have, you should be able to name off some interventions that we can do for AW to help her safely through her postpartum period.
All right, guys, see you on Tuesday.